My name is Thorsten Bach. I'm chairing the Asklepios West Klinikum in Hamburg, Germany, and I'm running there a department basically focusing on endourology with the main emphasis on BPH. And since we have this special interest in BPH, we have the ability to offer all kinds of possible treatments as recommended in the EAU guidelines. Well, as you know, aquablation is a surgical method where we treat BPH using a high velocity water jet controlled by a robotic unit. And we use this in terms of an ultrasound real-time planning where we mark the adenoma of the prostate that needs to be removed by the high velocity water jet. And usually the water jet runs one pass through this previously marked area. And what we did in this study, actually, we were testing if we repeat the same contour to do a second pass in the same previously planned contour, if this would lead to better outcomes, especially in terms to better early functional results because of more precise, or not more precise, but a more complete removal of necrotic tissue or fibrotic tissue as created by the water jet. And the findings, actually, what happened is that we looked into patient data of patients that have been treated with one pass or patients that have been treated with two passes. And what we found out that two passes are significantly more effective in terms of functional voiding outcome. Interestingly, not only in early functional results, but also in midterm follow-up after 2 and after 3 years, IPSS improvement and Qmax improvement is significantly superior when two passes are carried out as compared to one pass. Interestingly, independent of the number of passes that you do, the prostatic fossa looks pretty much the same. So after aquablation, what happens? The high velocity water jet goes through the tissue, removes the tissue, and ruptures tissue bridges, collagenous tissue bridges that leave like the leftovers, like a little bit fibrous tissue image. You see these white fluffy fibers at the bottom of the prostatic fossa. And if we do a second pass, actually it looks more or less the same. The feeling from a surgeon's eye might be that this fibrous tissue looks a little bit lighter or probably not that dense, but this is just, I would call it almost like a gut feeling. In general, there is no big difference. Yeah, this is something I need to correct you in. Bleeding complications have been an issue in the very beginning, not from the very beginning, only in the very beginning, because in the very beginning we were working completely athermal, and we have learned that if we have bleeding complications after aquablation, it's always arterial vessels at the bladder neck. So we switch from completely athermal to focal bladder neck cautery, spot cautery of bleeding vessels at the bladder neck. And since we're doing this, bleeding complications is not an issue anymore in aquablation. In contrast, we have a very low bleeding and transfusion rate now after we introduced spotlight focal cauterization at the bladder neck. However, if we do two passes, there is no significant difference in bleeding. The only difference is that the surgical time doubles in length, which is then in aquablation, the resection time doubles from 3 to 4 minutes to 6 to 8 minutes, which prolongs the surgery a little bit. But to be honest, 3 or 4 minutes more of surgery does not matter. independent of the experience of the user, we strongly recommend to do 2 passes independent of prostate size. Because we learned from the study that we have discussed that 2 passes result in superior functional and other outcome after aquablation in even midterm follow-up of 36 months. So in conclusion, it makes sense to perform a second run-through to get better outcomes for your patients. And me and my department, I have now treated over 750 patients with aquablation, and we do it routinely, independent of prostate size, also in not only in very large, but also in small or medium-sized prostates.